Welcome. Today we're doing a focused exploration into managing colorectal polyps in a specific patient group, those with a limited life expectancy, which the guidance defines as under 10 years.
That's right. We're looking at the BSGA CPGBI guidance here.
And it's really about that tricky balance, isn't it? Weighing the risk of a polyp turning malignant against the immediate risks of actually removing it.
It is. And this guidance, which involved a huge amount of work from gastroenterologists, surgeons, geriatricians, nurses, even patient reps.
Important to have their input.
Absolutely. It gives us a framework for what's becoming a more common challenge.
Because we're finding more polyps in older, more comorbid patients.
Exactly. Our population is aging, we investigate more readily, detection's better, so we face this decision more often.
And the goal of this guidance? To help us make more objective, informed decisions with our patients.
Precisely. It's aimed squarely at us as gastroenterology consultants dealing with these complex scenarios.
So let's get into the core issue. Why is this such a clinical dilemma? Is it recognizing that sometimes doing less is actually better?
That's a good way to put it. In someone with less than, say, 10 years life expectancy, the whole risk-benefit picture changes quite dramatically.
How so?
Well, think about polyp progression. Most take a long time, often more than 10 years, to become a symptomatic cancer that actually causes problems.
So within that patient's remaining lifespan, the polyp might just sit there harmlessly.
It might, but at the same time, these patients often have more comorbidities. They might be frail.
Which increases the risk from the procedure itself.
Significantly. Complications like bleeding or perforation, which are serious anyway, can be catastrophic in this group. Higher morbidity, higher mortality following a complication.
Right. Immediate harm from intervention, potentially outweighing a future, maybe uncertain, risk from the polyp. And you said this is happening more often.
Definitely. More older patients, more people with multiple health issues undergoing colonoscopy. And a qualitative study actually highlighted this uncertainty clinicians face.
Uncertainty about what specifically?
About how long polyps really take to grow, about predicting individual life expectancy accurately, and the true risks of polypectomy in this group.
Leading to potential overtreatment.
Yes, the tendency was often towards intervention. This guidance aims to bring more evidence, more structure to that decision.
It sounds like the process for developing this was pretty robust, not just a quick consensus.
Oh, absolutely. Very comprehensive. As I mentioned, a broad multidisciplinary group.
Gastroenterologists, surgeons.
Geriatricians, anesthetists, epidemiologists, specialist nurses, a GP, and patient representatives. They did a deep dive into the literature.
Looking at polyp natural history.
Yes. Polyp dwell time, cancer sojourn time, how long cancer is there before symptoms, plus life expectancy scores, and crucially, colonoscopy and polypectomy risks in these specific populations.
Using things like medical subject headings for the search.
Exactly. Very systematic to capture all the relevant studies.
And they didn't just review literature, they used modeling too.
They did. A semi-Markov state transition model. It's a sophisticated way to simulate outcomes.
Simulate outcomes for doing the polypectomy versus not.
Precisely. Comparing immediate polypectomy versus conservative management, they looked at different polyp sizes, tiny ones, 5 millimeter, right up to 20 millimeters plus.
And factoring in comorbidity.
Yes, using the Charlson Comorbidity Index, the CCI. And they even created separate models for patients on antithrombotics because the risks are different there.
So the model essentially pits the number of cancers avoided against the number of serious complications caused.
That's the core comparison. How many symptomatic cancers develop if you wait versus how many significant adverse events needing hospitalization happen if you resect.
And that led to the recommendations. Favor resection, favor conservative, or marginal.
Exactly, based on that balance for different polyp sizes and CCI scores.
Okay, before we get into those recommendations, let's nail down that definition again. Limited life expectancy is strictly
Mean life expectancy of less than 10 years. That's the specific threshold used throughout this guidance.
why 10 years.
It aligns reasonably well with the time frame for a significant number of adenomas to potentially progress to cancer. It helps focus on the group where the risk-benefit balance really shifts.
Got it. And who is this guidance not for? Any key exclusions?
Yes, important to be clear. It doesn't cover patients with temporary illness or frailty that might improve.
Okay.
It also excludes diagnosed colorectal cancer, hereditary syndromes like FAP or Lynch, or inflammatory bowel disease. Those need different approaches entirely.
Right, so we're focused on sporadic polyps, in patients with under 10 years expected survival due to age or chronic illness, none of those other conditions. So what factors do we need to weigh up?
It boils down to three main areas. First, patient factors. Critically, their estimated life expectancy, which we'll discuss more, their functional status, how resilient they are likely to be if a complication happens.
And their wishes, presumably.
Absolutely fundamental. Their wishes, their concerns, their personal goals for their health. It has to be patient-centered.
Okay, patient factors first. Then the polyp itself.
Yes. Polyp size, morphology pedunculated, sessile, its location in the colon. Is it one polyp or many? Histology, if we know it.
Any features suggesting malignancy already?
Right. Or high risk of becoming malignant. And importantly, is it actually causing symptoms? Bleeding, obstruction. A big symptomatic sigmoid polyp is different from a tiny, flat, cacal one.
Makes sense. And the third area, therapy-related factors.
Yes. What are the options for removal? Simple snare, complex EMR or ESD, surgery. How likely are we to succeed completely?
And the risk of complications for that specific procedure in this specific patient.
Exactly. Given their health, their medications, it's a synthesis of all three. Patient, polyp, procedure.
Okay, now thinking about investigation in this group, should we automatically investigate every polyp found, like we might in a younger person?
The guidance argues strongly against that. Investigations should only happen if the result might actually lead to a management change that benefits the patient.
Shared decision-making again.
Crucial. For someone very frail with a very limited expectancy, the burden of prep, sedation risk, maybe stopping anticoagulants.
Might outweigh any benefit of finding a small polyp that won't cause trouble anyway.
Precisely. So for some very unfit patients, the guidance suggests maybe a CT abdomen pelvis for prognostication instead of a full colonoscopy or CTC.
Why CT?
Less invasive, identifies major issues, but avoids the risk of finding and then feeling obliged to treat lots of small, clinically irrelevant polyps.
So the key is setting a threshold for intervention before you investigate.
Yes. Ask. If we find something, what are we realistically going to do, and would that genuinely help this patient? Define the therapeutic intent up front.
That prevents acting on incidental findings that aren't in the patient's best interest. What if we were doing a scope for another reason and find a polyp incidentally?
Good question. Ideally, that threshold discussion happens first, but in reality, we make decisions during the procedure. The guidance suggests it's generally reasonable to remove polyps amenable to cold snare polypectomy if you judge it safe at the time.
Because cold snare is lower risk.
Particularly for smaller polyps, yes. But even then, the broader principles and recommendations based on size and comorbidity should ideally inform that on-the-spot decision.
You've mentioned the Charlson Comorbidity Index, CCI, a few times.
Yeah.
That seems pretty central here for assessing life expectancy.
It is. Predicting individual life expectancy is notoriously difficult, but the CCI gives a more objective, standardized way to quantify the burden of a patient's other illnesses.
Better than just looking at their age.
Much better. Age alone doesn't tell you enough. An 85-year-old who's fit versus an 85-year-old with multiple severe conditions have very different outlooks.
Right.
The CCI assigns weighted scores to different conditions. Higher score generally means higher mortality risk, and it's validated for predicting risk up to that 10-year mark relevant here.
So it's more granular, more clinically relevant for this purpose.
Exactly. Other scales, like the Rockwood Frailty Scale, are good for assessing physiological reserve.
Yeah.
But for estimating mortality risk over the specific time frame, the CCI is what the guidance recommends.
And standard age-based life expectancy tables aren't enough.
No, they're population averages. They don't capture individual health status. The CCI helps individualize that risk. There's even a link in the guidance to an online calculator.
On MD-Calc.
Yes. And importantly for this guidance, it's the CCI score itself we need, not necessarily the calculated 10-year survival percentage some tools give. The score feeds into the risk categories.
So higher CCI generally means shorter estimated survival, informing the decision.
That's the principle. And the guidance stresses identifying this comorbidity and frailty early, ideally before referral or at referral.
So maybe a clinic review before deciding on a scope.
Often very appropriate, yes. To calculate the CCI, assess frailty properly before committing to an invasive procedure in potentially high-risk individuals.
Okay, let's switch focus to the polyps themselves.
Mm-hmm.
What's the risk of them progressing to symptomatic cancer in this older group?
Well, our understanding is still evolving, but based on large studies like Brenner's, the guidance gives some useful estimates. Average annual cancer transition rates based on size in an older population.
What are those rates roughly?
For big polyps, 20 millimeters or more, it's estimated around 10% per year. For 10-19 millimeter, about 3.3%.
Okay.
For 6-9 millimeter, maybe 1%. And for the really small ones, 1-5 millimeter, it's down at 0.2% per year.
Those figures really drive home that small polyps are very unlikely to cause cancer within that 10-year window for many of these patients.
They are. And then you add the cancer sojourn time, the delay between becoming malignant and causing symptoms.
How long is that estimated to be?
Average around 3 years, maybe up to 6, based on trials like NORDI-CC, so there's another significant lag.
Meaning only a minority actually progress and become symptomatic within a limited lifespan?
Exactly. The model used in the guidance was built on Brenner's data for those transition rates, enhanced with UK data on adenoma size and malignancy rates.
So a slow process generally. If a patient has limited time due to other issues, the chance of symptomatic cancer from a small polyp is often much lower than their risk from other things.
That's the core rationale for considering conservative management.
Right. Now, the flip side, the risks of removing them. How do we assess and manage those risks?
Careful endoscopic assessment is still key, looking for signs of cancer. And using the SMSA score, size, morphology, site, access, helps quantify the technical difficulty.
But always keeping overtreatment in mind.
Always. Is the risk of this procedure worth it for this patient?
Is there a preferred removal technique?
Yes, the guidance strongly recommends cold snare polypectomy whenever it's suitable.
Why cold snare specifically?
Significantly lower risk of delayed bleeding, perforation, and post-polypectomy syndrome compared to hot snare. It's also generally quicker and cheaper, especially for smaller polyps.
Are there factors that clearly increase complication risk?
Definitely. Polyp size bigger is riskier. Location, the cecum, is often considered higher risk.
And pacing factors.
Advanced age, being on antithrombotics, and significant heart, lung, or kidney disease all increase the risk.
Antithrombotics are a big one in this group, aren't they? How do we manage that?
It's a major challenge. Stopping them increases thromboembolic risk, especially if the polyp is small and low risk anyway. Continuing them increases bleeding risk significantly.
So a very careful individual risk-benefit calculation is needed.
Absolutely. Ideally, discussing with the prescriber, it's very nuanced.
Does the guidance give actual numbers for complication risks?
It does, based on their modeling, estimated significant complications needing hospitalization per 1,000 elderly comorbid patients.
Can you give some examples?
Sure. For small polyps, 1-5 millimeter, maybe 10 per 1,000 off antithrombotics, but 30 per 1,000 on them.
Triples the risk.
Roughly. For 10-19 millimeter polyps, it's maybe 25 per 1,000 off, 75 per 1,000 on, and for large ones, a 20 millimeter, it's 45 per 1,000 off, jumping to 135 per 1,000 if they're on antithrombotics.
Wow. That really highlights the procedural risk, especially with antithrombotics.
Yeah.
And the consequences if something does go wrong.
Much more severe in this group. Less physiological reserve means complications can lead to longer stays, worse outcomes, even death.
Should we be thinking about surgical risk too?
Yes, the guidance suggests considering tools like CR-POSSUM to estimate the risk if surgery becomes necessary after an endoscopic complication. It's all about that balance, bleeding versus clotting.
And reinforcing the preference for cold snare again.
Yes, lower risk, similar effectiveness for complete resection where appropriate. And there's growing evidence you can often remove very small polyps safely without stopping antithrombotics, maybe using clips.
But needing experienced endoscopists and clear patient advice.
Essential. The guidance acknowledges uncertainty in these risk numbers, but they're derived from the best available data synthesized from multiple studies.
Okay, so we have polyp risks, procedure risks. How does the guidance pull this together into management recommendations?
It stresses these are based on modeling and expert opinion to support shared decision-making. There's still uncertainty, which we need to explain to patients. Decisions must be individual.
And polypectomy is only appropriate when
the benefit preventing a future symptomatic cancer clearly outweighs the procedural risks for that individual patient.
Are there times we do it even if cancer risk seems low?
Yes, if the polyp is causing significant symptoms like bleeding or pain, then it's about palliation, improving quality of life now.
And when should conservative management be strongly considered?
If there are no symptoms and the estimated likelihood of that polyp progressing to cause symptomatic cancer within the patient's limited lifespan is very low, especially for small polyps in comorbid patients.
And that decision isn't set in stone.
No, it's reversible. If the patient's situation changes or the polyp changes, the plan can be revisited. Table 1 in the guidance summarizes the model outputs for different scenarios: polyp size, CCI score. It's a useful starting point.
But we need to remember the model's limitations.
Exactly. It assumes equal harm from therapy versus cancer, doesn't fully capture timing, or polyp multiplicity. It's a guide, not a rigid rulebook.
If we decide on conservative management, what about follow-up? Do these patients need ongoing surveillance?
Generally, no. The guidance recommends against routine endoscopic follow-up for conservatively managed polyps in this group. Discharge back to the GP for best supportive care is usually appropriate.
Why no surveillance?
Because the risks of repeated preps, sedation, stopping antithrombotics likely outweigh any small benefit of finding something new in someone with limited life expectancy. The risk-benefit equation doesn't improve over time.
Are there exceptions?
Maybe in very select cases where the initial decision was marginal or difficult. Then perhaps a defined period of surveillance with clear goals, but that's the exception.
So clear communication about the plan is key.
Absolutely. Written info for the patient and the referring clinician, outlining the plan and crucial trigger points, symptoms that should prompt review.
And what if they do have a polypectomy? Is standard surveillance needed then?
Usually not beneficial either. Their future risk is even lower after removing the index polyp, while procedural risks remain or increase. But again, individualized, consider polyp histology, completeness of clearance, etc.
This is definitely complex. How should we handle these decisions practically? Multidisciplinary teams.
Strongly recommended. A dedicated polyp MDT is ideal, separate from the cancer MDT but with overlapping members. You need input from endoscopists skilled in different techniques, surgeons, ideally someone who knows the patient well.
And having the CCI score ready for the MDT discussion.
Invaluable. Having that prognostic information helps frame the discussion.
And involving the patient.
Paramount. They or their advocate must be central. Discuss life expectancy sensitively, polyp natural history, complication risks, consequences.
Where should these discussions happen?
Ideally not rushed in the endoscopy unit. A separate clinic setting after MDT review led by experienced clinicians with good communication skills. Allow time, involve family.
Sounds very much like the principles of realistic medicine.
It aligns perfectly. Personalized care, shared decisions, reducing harm and waste, managing risk, tackling variation, improving continuously. Acknowledge uncertainty, tailor to the individual's context and preferences.
Objective talk about life expectancy can actually improve consent.
Yes, it makes it more realistic and ensures decisions align with the patient's values.
And now there's no formal polyp MDT.
The principles still apply. Seek multidisciplinary input informally. Document risks and benefits clearly in the context of life expectancy. Think ahead about managing complications, surgical fitness.
And always remind patients conservative management can be revisited.
Always. The guidance appendix has examples of shared decision aids too.
This has been incredibly useful. So to summarize the key take-homes from this guidance for our colleagues.
The main message is, managing polyps in patients with 10-year life expectancy requires a shift away from automatic removal towards individual risk-benefit assessment and shared decision-making.
Considering comorbidity via the CCI.
Yes, polyp characteristics, overall health, patient wishes, and recognizing that often conservative management is the right approach to avoid overtreatment and harm.
So a more nuanced, patient-first strategy.
Exactly. It's about applying this evidence-based framework with careful clinical judgment, good communication, and recognizing our understanding is still evolving. Hopefully this discussion helps you think about how to apply these principles in your own practice.